Welcome back to our Community Medicine Revision series. Today's topic is PEM or Protein-Energy Malnutrition. Dr. Joshi, could you begin with a crisp, exam-ready definition and the classic clinical forms?
Certainly. PEM is a spectrum of undernutrition resulting from deficient energy and often protein, usually accompanied by micronutrient deficits and recurrent infections. The three bedside forms are Marasmus, severe wasting without edema; Kwashiorkor, edema with fatty liver, skin and hair changes; and marasmic Kwashiorkor, wasting plus edema. It mainly affects children under 5, especially between 6 to 24 months when breast milk alone is insufficient and complementary feeding is poor.
For Viva structure, how should students classify PEM? Clinically and anthropometrically.
Clinically, use the triad I just outlined. Anthropometrically, quote the World Health Organization WHO Child Growth Standards. Severe acute malnutrition SAM is defined by any one of weight for height Z score below -3, mid-upper arm circumference MUAC below 11.5 centimeters, or bilateral pitting edema. Moderate acute malnutrition, often called MAM, is weight for height Z score from -3 to -2 or MUAC 11.5 to 12.5 centimeters without edema. For chronic undernutrition, use stunting, where height for age Z below -2. Older exam systems may ask Gomez, weight for age percent, or Waterloo, wasting and stunting separately. State WHO first, then mention the older schemes.
Great. Before causes, a quick pause and recall. What three anthropometric flags define SAM? Answer after a beat: Z below -3, MUAC below 11.5 centimeters, or bilateral edema.
Causes are multi-layered. Immediate determinants are inadequate dietary intake and infection, forming a vicious cycle. Underlying determinants include suboptimal infant and young child feeding practices, food insecurity, poor water, sanitation and hygiene, low caregiver knowledge, and inadequate health services. Basic determinants span poverty, gender inequality, and disasters. Pathophysiology explains the phenotypes. In Marasmus, energy deficit drives catabolism of fat and muscle. In Kwashiorkor, oxidative stress and impaired hepatic protein synthesis lead to hypoalbuminemia, edema, dermatosis, and fatty liver.
Let's anchor this with a vignette. Case 1, 18-month-old boy from an urban slum has weight for height Z -3.2, MUAC 11.0 centimeters, peeling lesions over legs and pitting edema of feet. How would you label and prioritize?
He meets SAM by all three flags. The dermatosis and edema suggest Kwashiorkor features. Priorities: urgent assessment for danger signs, lethargy, hypoglycemia, hypothermia, dehydration, sepsis, and severe anemia. If any are present, he needs inpatient stabilization. If clinically stable without complications, he can be enrolled in community-based therapeutic care with weekly follow-up and ready-to-use therapeutic foods where available.
Students often mix up screening and diagnosis. In the community, what is the simplest, reliable screening tool?
Shakir's or MUAC tape. It is cheap, quick, and color-coded. Red band below 11.5 centimeters suggests SAM. Yellow 11.5 to 12.5 centimeters without edema. Green is acceptable. Combine it with edema check and recent illness history. Growth monitoring with monthly weight plotting remains foundational in primary care and Anganwadi centers.
Could you outline key clinical features that examiners expect for Marasmus and Kwashiorkor?
In Marasmus, market wasting with old man faces, baggy pants buttocks, irritability but alertness preserved, voracious appetite, no edema. While in Kwashiorkor, bilateral pitting edema beginning at feet, flaky pain dermatosis, sparse, easily pluckable hair with flag sign, apathetic child, enlarged fatty liver and poor appetite. Remember, mixed forms exist.
Management is the heart of scoring. Can you give the WHO-style 10-step framework in simple exam language?
Yes, think stabilize then rehabilitate. Treat and prevent hypoglycemia, where you check capillary glucose, give starter feed or IV dextrose as needed. Treat and prevent hypothermia with warm room, skin-to-skin contact and covering the child. Treat and prevent dehydration using low-sodium rehydration like rehydration solution for malnutrition, not standard ORS, and avoid rapid IV fluids unless in shock. correct electrolytes where you assume deficits, give extra potassium and magnesium, avoid excess sodium. Treat infections for which you start broad-spectrum antibiotics empirically because signs can be muted. Correct micronutrients by daily multivitamins, vitamin A if deficient, no iron in the first phase, start iron only after appetite returns and weight gain begins. Start cautious feeding with small frequent feeds with starter formula, which is energy dense, low sodium, moderate protein. Achieve catch-up growth by shifting to higher energy, higher protein feeds once the child is stable. Sensory stimulation and emotional support by play therapy and maternal involvement. Prepare for follow-up, where you teach caregivers the signs of danger, feeding plans, immunization catch-up, and scheduled reviews.
Pause and recall. Why is standard ORS avoided initially? Because sodium load is high and can worsen edema and heart failure risk in severely malnourished children.
Exactly. Also remember appetite test protocols used in some programs to decide inpatient versus outpatient care. Poor appetite or complications means admission.
Case 2. A 2-year-old girl, weight for height Z-2.4, MUAC 12.0 centimeters, no edema, frequent diarrhea, and very poor dietary diversity. How would you apply the cafeteria approach to counseling her mother?
This is moderate acute malnutrition. Use respectful, tailored counseling. First, treat incurrent illness and deworm if indicated. Next, improve diet quality. Encourage one animal source food where culturally acceptable. Add oil to porridges to raise energy density. Offer mashed family foods 5 to 6 times a day with active feeding. Demonstrate hygiene at preparation and feeding. Arrange weekly weight checks and problem-solving visits. If local policy allows, provide fortified blended foods or community supplements. Pause and reflect which single behavior often raises energy intake the most. Answer is increasing meal frequency with energy-dense additions like oil or groundnut paste.
Where do national programs fit in, like integrated child development services and facility-based care?
Integrated Child Development Services offer supplementary nutrition, growth monitoring, and referral through Anganwadi centers. Facility-based management of severe acute malnutrition handles complicated cases with trained staff, starter and catch-up feeds, and structured discharge plans. Community-based management treats uncomplicated SAM at home with therapeutic foods, weekly reviews, and strong counseling.
Prevention now. What are the big 3 pillars you would write in the answer book?
Optimal infant and young child feeding with early initiation within 1 hour, exclusive breastfeeding for 6 months, appropriate complementary feeding from 6 months with continued breastfeeding to 2 years or beyond, infection control with full immunization, vitamin A prophylaxis where indicated, deworming, prompt treatment of diarrhea and pneumonia, and safe water, sanitation and hygiene. Food and social security through public distribution systems, cash or food support for vulnerable households, women's education and empowerment, and behavior change communication.
Students worry about Viva traps. What are 2 commonly tested pitfalls?
First, missing edema. Always press over the dorsum of the foot for 3 seconds. Second, starting iron too early. Give iron only after the child is warm, infections are addressed, and catch-up feeding has begun. A third is overhydration with standard ORS or rapid infusions. Avoid unless pinch shock and then use cautious protocols.
How do you link PEM with community indicators like body mass index or BMI or household surveys?
For under 5s, we rely on weight for height, height for age, weight for age, and MUAC, and not on BMI. Household surveys report prevalence of wasting and stunting against WHO standards. As a community physician, you interpret clusters with high wasting as acute crises needing immediate nutrition and infection control, while high stunting points to chronic deprivation demanding multi-sectoral fixes.
A tight exam pad wrap-up, please, Dr. Joshi.
Define PEM as a spectrum due to insufficient energy and protein with infections. Clinical forms are Marasmus, Kwashiorkor, and mixed forms. WHO classification uses Z-scores, MUAC, and edema. No SAM and moderate acute malnutrition cutoffs. Screening with MUAC and edema check. Confirm with growth standards. In management, stabilize first. Hypoglycemia, hypothermia, dehydration, electrolytes, infection, micronutrients. Then cautious feeding, catch-up growth, stimulation, and follow-up. Community care for uncomplicated cases, facility care for complicated. Prevention rests on infant and young child feeding, infection control, and social protection. Always counsel with empathy, involve caregivers, and plan follow-up.
Pause and recall. List the 10 stabilization steps in order. If you can do that, you are exam ready. Thank you, Dr. Joshi, and happy revising, everyone.